Good afternoon, everybody. Welcome to today's webinar hosted by Inneg on ophthalmic consequences of brain injury in children. Professor Jane Ashworth has kindly agreed to speak to us today, and the topic poses to be very interesting. For everyone's interest, Professor Ashworth also wrote a blog on cerebral visual impairment for us a little while ago, and that can be found on the Inneg blog at a later date if the topic is of interest and one wants to read and understand a little more. Today, just to run through a few things, obviously the webinar will be approximately 40 or so minutes. There will be a Q&A session afterwards, so please feel free throughout the webinar to pitch any questions you have in the Q&A function above, or the chat function. You'll see it at the top of your screens, and Professor Ashworth will look to, well, answer as many of those as we can following her presentation. Just to introduce Inneg to you, I know there's a lot of people here who we've worked with before, plenty of people who we haven't. Inneg, we are a specialist, bespoke, boutique, you might say, medical agency. We support solicitors who specialize predominantly in clinical negligence or serious and catastrophic injury. And we do that by looking to provide above and beyond support to accelerate the claim life cycle and reduce unrecoverable costs for the solicitor partners who we work with. We do that in several ways. That's for another day, for another topic. But obviously, if you have any inquiries for Professor Ashworth or potentially for other medical experts that you might require in bespoke disciplines across a whole range of medicine, allied health, surgery, and the like, then of course email out to us. There will be a copy of this webinar going out with slides following the event. And without further ado, if I can introduce you to Professor Ashworth to begin the webinar. Thank you very much.
Thank you very much for the introduction. Yes, I'm Jane Ashworth. I'm a consultant paediatric ophthalmologist at Manchester Royal Eye Hospital. And I'm going to talk today about brain injuries in children. So brain injuries can occur for a variety of reasons. They can be due to birth injuries, which are a major topic of medical legal cases, traumatic births leading to conditions such as periventricular leukomalacia, hypoxic ischemic encephalopathy. Brain injuries are more common in children that are born prematurely, and then they can occur after birth as well due to conditions such as hypoglycemia, or as a consequence of surgery for tumours or anaesthetic complications, and then, of course, due to trauma. So we're all more familiar with the effects of brain injury on general development and growth. As you probably know, brain injuries early in life can lead to conditions such as cerebral palsy, with physical issues and developmental delay and effects on speech, mobility, cognition. But as well as that, brain injuries can lead to a visual impairment and also visual processing issues. And this is a condition that we term cerebral visual impairment. So I'm going to talk a bit today about vision processing and development in general, about cerebral visual impairment and some of the other ophthalmic conditions that can occur with brain injuries. So this is just an image taken from the CVI Now website, and it shows the eye and the connections of the eye to the brain through the optic nerve, the optic pathways with the lateral nucleus, and then the optic radiations taking the nerve signals from the eye to the brain to the visual cortex, which is the occipital region at the back of the brain. And from there on, there are other areas of the brain, such as the parietal and temporal cortex, which are also involved in visual processing. So this is another image looking at the eyes at the top there and the brain behind. And you can see that the optic nerves take the nerve fibers to the chiasm, where the half of the nerve fibers from each eye cross over. And so the nasal half of the retina the fibers that are connected to the nasal half of the retina of each eye cross over at the chiasm and then go on through the optic tract and then the optic radiations to the brain. And so the left visual cortex receives all the information from the left half of the retina from each eye, and therefore is responsible for vision in the right visual field, and the right visual cortex is the other way around, which is why you can get these hemifield visual field defects. And brain injuries can affect any of the parts of the visual pathways and the parts of the brain that can affect visual processing. So I'm going to talk a little bit about visual development and maturation because it's relevant to this topic. Visual development starts at about 6 weeks of age, but as you know, there's a lot of variation in that, and some babies can be very visually alert from birth, and others don't develop their visual behavior until a few weeks old. Most babies are able to fix and follow readily by about the age of 2 months. Premature babies don't start developing their vision until their corrected age. In other words, they can be older when they start developing their vision. Binocular function, which is the ability to use both eyes together, develops in the first 6 months. And visual development overall occurs up to the age of about 7, 8, 9 years. And that's for all children, whether they've got a brain injury or not. So during that time, if there's something that interrupts visual development, which could be an uncorrected need for glasses or the presence of a squint or an injury to the eye, a child can develop amblyopia where the visual development falls behind in one eye compared to the other. And this is managed, as you may know, with glasses or, if appropriate, or patching or atropine eye drops to penalise the better eye. And the success in treating amblyopia depends on how well the child is able to wear the glasses and how well the patching is adhered to. Delayed visual maturation, which is a condition which is relatively common, and it's when a child has poor visual attention and inability to fix and follow from birth, and the vision doesn't start to kick in until later than you'd expect, really. So typically a child has poor visual behavior and the parents are concerned that they're not following and they're not visually alert, and it usually improves at about 3 to 6 months of age. Type 1 delayed visual maturation is seen in babies who are otherwise completely well, and their vision develops normally and there's no neurological or other abnormalities. And type 2 occurs in children that have other issues going on, which can be neurological conditions such as a brain injury, or sometimes problems with the eyes themselves, and those children can have persistent visual impairment even after the initial improvement. So cerebral visual impairment is this condition which we use to describe visual issues that have arisen not due to problems within the eye itself, but within the brain and the parts of the brain that are responsible for visual processing and the visual pathways. Often there is delayed visual maturation as well, but the true extent of visual processing problems may not be apparent until early childhood, and the child starts to be more independent and wanting to do more things. It's an area that's not been very well understood until fairly recently. And in the last few years, there's been a big increase in literature and a big increase in our understanding about cerebral visual impairment, about when to diagnose it and how to diagnose it. And there's been a few key publications, for example, this 2023 publication from the Royal College of Ophthalmologists, which is a document called Concise Practice Points about diagnosing and assessing children with cerebral visual impairment. And there are quite a few children out there who have not had a diagnosis when they probably should have done. Most children have a normal eye examination, but not all. I'll come to that later. So how does cerebral visual impairment affect children's vision? I mean, there's a wide range. Some children have very severe visual impairment with very poor visual acuity and very poor visual behavior. And other children have quite good visual acuity, and many aspects of their visual behavior are normal, but they have visual processing defects. And it can be very difficult to quantify and objectively measure the visual processing defects, particularly in children who have cerebral palsy and learning difficulties. The type of effects that it can have are affecting visual acuity, so they may have poor general visual acuity. It can reduce contrast sensitivity. It can affect visual fields. And I'll talk a bit more about that. And it can cause perceptual and cognitive visual impairment. When we look at the way vision is processed within the brain, it's divided into dorsal and ventral stream processing. And you don't really need to know how to distinguish them, but just to know that they are something that's sometimes mentioned. And the dorsal stream visual processing are the pathways from the occipital lobe, which is right at the back of the brain, to the posterior parietal cortex, so the superior process. Yeah, I don't know if I can use my pointer, maybe not. Oh, sorry. And the ventral stream goes from the occipital cortex to the infratemporal parts of the brain. And the dorsal stream is thought to be responsible for integrating visual information to guide movements and action, to lead to accurate guidance of movement of the body. So children that have defects in this area will be bumping into things and clumsy and have poor hand-eye coordination. The ventral stream processing is responsible for storing previous visual experiences and recognizing and understanding what they are. And so damage to this processing stream impairs visual recognition, which can be recognition of faces, objects, impaired route finding, and children may not be able to copy and draw things or remember where things are. So how does this affect visual function? Often children with cerebral visual impairment have characteristic features of their vision, which are things like variability in visual function. So some children may see much better when they're in their home environment or a familiar environment, and appear to be able to function visually much worse when they're in unfamiliar environment, or when they're tired or unwell. Often children have difficulties with cluttered visual scenes and complex environments, so they might have much worse vision when they're in a busy environment or they're out in a crowded area. They'll have difficulties locating toys on a patterned background. They may not be able to see things at a distance. They may not be able to navigate well. They may bump into things. They may not be able to recognize people, and maybe able to not be able to pick out their parents in a crowd when they're being picked up from school, for example. And they may not be able to see movement. So if you throw a ball towards them, they may not be able to see it until it's very, hit themselves. There are many questionnaires that have been developed to try and assess visual function in children with cerebral visual impairment. And some of them have very extensive questioning, up to 50 questions per questionnaire, but it's useful to have some screening questions, which will give you an idea whether a child has cerebral visual impairment when they've got a brain injury. And the questions that I ask are usually, first of all, I ask about variability, which isn't on this slide, but just say, does your child appear to be able to see better when they're in a familiar environment and well rested and feeling well? Does your child have difficulty walking downstairs? Because children often have difficulty with steps and stairs. They may not be able to see the step and maybe trip. They may not be able to see changes in terrain when the floor changes from a carpet to a wooden floor, for example. Does your child have difficulty seeing things which are moving quickly? And I usually ask, would the child see a ball being thrown towards them, or would they see a car passing, for example? Does your child have difficulty seeing something which is pointed out in the distance? And often children don't see something till they're quite close, within a few meters range. Does your child have difficulty locating objects in a cluttered pile? And often that is the case, and things need to be separated. Even things like food needs to be separate on the plate. And does your child find copying single shapes or words difficult? Some of these things are not relevant in a child who's got severe learning difficulties. It can be quite hard to assess visual function in that situation. So practically, how does this affect a child? Well, if they have reduced visual acuity and a visual field defect, obviously they may not be able to drive, because you need to have full fields horizontally and a good level of visual acuity to do that. But they also may not be able to be independent navigating, crossing roads, using public transport, even when they have quite good visual acuity. It may impair their ability to carry out tasks of daily living. They may be clumsy, have poor hand-eye coordination, bump into things. They may not be able to manage steps or stairs, which may require modifications to their home or environment. And often children with cerebral visual impairment may miss things in their lower visual field. They may trip over things on the floor or not see their food on the lower part of the plate. And often the things need to be raised up for them to see them. And they may not be able to socialize or take part in sports and activities. So it's fairly recent, the concept has been understood that cerebral visual impairment can be diagnosed and can occur even when the visual acuity and visual fields are normal. And so there are children, as I say, under ophthalmology already who may not have a diagnosis when they should have. And this paper a couple of years ago from the Great Ormond Street group published in 2021 was particularly helpful in this regard because it classified children with cerebral visual impairment according to 3 subgroups, A1, A2 and B, looking at 63 children with suspected or diagnosed cerebral visual impairment. And Group A1 had normal visual acuity, but had either normal visual fields, but had symptoms and signs of cerebral visual impairment on questioning and on psychovisual testing. So that was nearly half the group. So how do we diagnose cerebral visual impairment? And again, the literature on this is improving. So it's generally thought that CVI is thought to be present if two of the it may be present if 2 of the 3 criteria are met, and is highly likely to be present if the child fulfills 3 criteria. And the first criteria is the presence of a risk factor. So a child with a brain injury, a known brain injury, would have this risk factor. Cerebral palsy is also considered to be a risk factor. And the second is reported or observed atypical CVI-related visual behaviours. And this can be determined by screening questions or by reported symptoms from the parents, or by a more extensive questionnaire if needed. And then the third criteria is verifiable visual dysfunction on examination. So this could be an orthoptic assessment or an ophthalmology assessment, or an assessment by educational psychology or neuropsychology. And it's easier if the child has reduced visual acuity or a visual field defect or nystagmus, but it becomes more difficult when the child doesn't have those things. And one area of uncertainty is, or there doesn't seem to be any consensus on which tests need to be done to help elicit the particular signs of cerebral visual impairment. So talking about visual field defects following brain injury, I mean, visual field defects are very common following brain injury and may not be apparent in early childhood because often children compensate for them. And also it's very difficult to assess visual fields in children because of concentration and cooperation. There can be a variety of visual field defects. Trauma may lead to a hemifield defect, such as this here, which is a homonymous hemianopia. The top 2 images are normal visual fields, and the little circles are the blind spots, which are normal. And then the bottom images show a right homonymous hemianopia, which can be due to damage to the occipital cortex on the left side, or optic pathways on the left side. And this can lead to difficulties with reading, for example, difficult seeing things to the right-hand side, and people may need to use a face term to avoid using their defective visual field. Children with cerebral visual impairment often have defective inferior visual fields, leading to them tripping over things or not seeing things below them. And also there's a thing called visual inattention, where the visual fields on testing are full, but children seem to sort of ignore things that are in their inferior visual fields. Nystagmus is a condition that often occurs in association with cerebral visual impairment or children with brain injuries. And it's the word that we use for the abnormal, involuntary, rapid to and fro eye movements. And if nystagmus occurs in an adult, for example, as a result of a brain injury or a tumour, then the world appears to that person to oscillate, which is what we call oscillopsia, which can be very distressing for a patient and very disruptive to their vision. But children who have congenital nystagmus or very early onset nystagmus, their brain seems to compensate for this, and they don't have oscillopsia. They don't have a symptom, generally speaking, of their vision wobbling, but it can result in reduced visual acuity. It can be horizontal or vertical or rotary or multiplanar, and it can vary depending on which way the child's looking. And often children use a head turn to utilize a null zone where the nystagmus is least. Strabismus or squints are very common in children with brain injuries and cerebral visual impairment. Squints are common anyway. About 1 to 2% of the general population has the squint, and sometimes it can be treated with glasses, or sometimes squint surgery is required. But it's very common in brain injuries and is thought to occur up to 50% of children with cerebral palsy. And it can be an esotropia when the eyes turned inward, such as the child at the top left and the child on the bottom, or it can be an exotropia, divergent squint, when the eyes turn outwards as a top right. In an adult, having a squint can cause double vision, but in children who have squints from an early age, they don't get any symptoms from it. It doesn't affect their vision, but they don't have binocular function. They don't have stereopsis, which is the ability to use both eyes together to get 3D vision, and amblyopia is common. And I'll talk a little bit later about management of squints. So children can have other eye diseases with their brain injury, and optic atrophy is common due to either hydrocephalus, raised intracranial pressure, or transsynoptic degeneration as a result of a severe brain injury. Children can have also ptosis, the drooping eyelids, and if they're born prematurely, they can have retinopathy of prematurity. So I'm going to talk a little bit about some specific situations. So first of all, cerebral palsy is common in children, as you know, with early brain injuries. And ophthalmic problems are very common in children with cerebral palsy. And about 1 in 10 children with cerebral palsy have severe visual impairment or blindness. And up to 70% of children with cerebral palsy have cerebral visual impairment. The majority of them have strabismus, refractive error, and amblyopia are also common, as are optic nerve abnormalities such as optic atrophy, nystagmus, and ptosis. Hydrocephalus is a specific example of a brain injury that can lead to ophthalmic issues. And I've come across quite a few medico-legal claims which are around the delay in diagnosis and treatment of papilledema, which is swollen optic nerves resulting from raised intracranial pressure. Raised intracranial pressure can occur due to many reasons: early onset brain injury or trauma or tumor, and it leads to swelling of the optic nerves, which we term papilledema. And you can see from the pictures, I don't seem to be able to use the pointer, but the middle picture at the top shows a normal optic nerve with a clearly defined margin, and the one to the right shows a very pale optic nerve. And then along the bottom row, you've got different levels of optic nerve swelling. Optic swelling can be graded at 1 to 5, and on the left is very subtle grade 1 papilledema, and on the extreme right is much more marked papilledema, and the optic nerve is really pushed forward by the raised intracranial pressure. And the early stages of papilledema, stage 1 and 2, can be often misdiagnosed as normal, and so may be missed at an optician or an ophthalmology appointment. And if not diagnosed early enough and not treated promptly, papilledema can lead to optic atrophy with visual field loss and visual acuity loss and loss of colour vision. So that's a source of medical legal claims. Brain tumours can cause hydrocephalus and papilledema, and they can also cause squints with cranial nerve palsies, sudden onset squints, such as this girl here who's unable to move her right eye outwards, leading to a convergent squint when the eyes turn inwards. And they can also, that's due to a 6th nerve palsy, but they can also lead to damage to the 3rd or 4th nerve, and ptosis, double vision, field defects, visual loss, and nystagmus. And again, late diagnosis or misdiagnosis of brain tumours is a common cause of medico-legal claims in the world of paediatric ophthalmology. There may be some recovery of the eye involvement, or it may be permanent. Trauma can cause injury to the eye and also to the nerves which supply the extraocular muscles. The extraocular muscles are supplied by the third, fourth, and sixth cranial nerves, and you can see the picture at the top shows the eye within its socket, and the yellow line or the yellow drawing shows the cranial nerves, and they're very fine nerves heading from the extraocular muscles towards the brainstem, and they're quite susceptible to trauma. And so this can lead to, a bit like tumours, can cause squints, double vision, and pupil abnormalities. This child at the bottom has a left third nerve palsy, so they've got a squint with their eye turned outward, and a ptosis, and they'll have a dilated pupil as well. So how do we assess vision in children when they're not able to read down the chart? Well, we do have ways that we can try and do this, although it's not always very easy. You can see there a logMAR visual acuity chart, which is kind of the gold standard for measuring visual acuity in the world of ophthalmology. And if you've got a child or a patient who can read the letters and knows the letters, then that's the way you choose to do it. But obviously many children with brain injuries are not able to do that. They may be non-verbal and have learning difficulties. So you can observe visual behaviour. You can see a child reaching for toys, responding to their parents. You can see if they're able to fix on a light or a toy, and if they're able to follow and maintain their fixation. We can do both eyes together or each eye separately. And if they won't do that, you can see if they'll respond to a bright light in a darkened room. There are other ways of measuring vision in non-verbal children using things such as preferential looking. At the picture at the bottom shows a baby looking at gratings made of different widths, black and white gratings, and the cards are held at appropriate distance from the child, and then the observer sees whether the child preferentially looks towards the circle made of gratings. You can see it's not particularly accurate, but a skilled person can get a reasonable assessment of visual acuity even in a baby that way. As children get older, we move on to Cardiff cards, which are the top right. And again, they use black and white lines of different widths, but the child, I don't know if you can see that, I can't see it on my slide, but the grey cards have pictures of things like cars or trees or ducks on them, and the observer stands at a fixed distance and sees whether the child looks at the picture preferentially as opposed to a blank grey card. That's Cardiff cards. And then we can also use Kay's pictures, such as the picture held there. If you hold the picture at a fixed distance and ask the child to either name the picture or match the picture using a test card, just point to the one that they see. And again, this is okay for children, but some children with learning difficulties and cerebral palsy are not even able to do these tests very well. So it's just a guide, really. And the Cardiff cards tend to overestimate vision. Ophthalmologists work in clinics with orthoptists who are specially trained to assess vision in children, particularly those who are non-verbal, and also assess eye movements, the angle of deviation for a squint, to assess nystagmus, and also they can assess contrast sensitivity and also binocular function, the ability to use both eyes together to get 3D vision. And there are techniques for doing this in adults and children. And these are things that are often affected in children with cerebral visual impairment or brain injuries. The eye examination, you may be familiar with, uses the slit lamp if somebody's able to cooperate and put their head on the chin rest. But again, children with brain injuries are often not able to do that. They might be in a wheelchair and immobile. So we have other techniques we can use, which is a handheld slit lamp or the indirect ophthalmoscope, which we wear on our head, as you can see at the bottom there, which lets us look at the eye and the retina in a child in a wheelchair or a baby. And also we can test for glasses using retinoscopy after putting drops in a child. It's very difficult to assess visual fields in young children or in those with learning difficulties. Even a child who's got normal development and normal cooperation is not usually able to do formal visual field testing until the age of about 10 years old. And even then, it might not be very reliable. We usually do visual fields to confrontation in children, as you can see at the bottom there. Just it's very crude, just holding out a finger and trying to match your field with that of the patient's. But it can give you a reasonable idea. And then if the child's able to, you can do Goldman visual field testing or Humphrey visual field testing, which is automated, giving a computer-generated printout, including things like reliability and repeatability. But the majority of children with brain imaging injuries are unlikely to be able to do any automated visual fields. So what do we do to manage children with visual problems and brain injuries? During childhood, we monitor visual development up to the age of about 7 or 8. The child will need to have regular assessments by an orthoptist, an ophthalmologist, and an optometrist. And as I say, we usually work together in a team. If the child's got squint or amblyopia or some visual concerns, then it's usually about every 6 to 9 months, something like that. And in that time, the child may need to wear glasses to optimize their visual development, or they may need to have treatment for amblyopia, such as patching or atropine eye drops to try and improve the vision in the lazy eye. Children with visual problems are eligible to be registered either full or partial certificate of visual impairment. To get a full certificate of visual impairment entitles you to some benefits, for example, but you have to have very, very poor vision in both eyes. Your vision has to be worse than 360 in your better eye. In other words, you can't even see the top letter of the chart. That's for a full certificate of visual impairment, but a partial certificate of visual impairment can be lesser levels of visual impairment and is also slightly more up to the discretion of the ophthalmologist. In school, visual impairment teachers go in and make sure that the child is using the right font size, sitting at the front of the classroom, and give advice on things like lighting and things like that. And then there are other things, depending on the level of visual impairment, such as mobility training, occupational therapy, assistive technology experts that can be helpful. The mainstay really of managing children with cerebral visual impairment is making modifications to the environment. And often parents, even when they are not aware of the diagnosis, have instinctually done these things for their child. Things like keeping the floors free of clutter, avoiding cluttered spaces and environments, and they may organising things into particular storage, label items. Obviously at school you can have enlarged text, increased spacing, a good contrast. Sometimes it's helpful to lift up the educational material into a higher position to avoid the inferior visual field defects, and avoidance of steps and stairs, say, because children may have difficulties on them. Other aspects of management, strabismus surgery is occasionally required in children with brain injuries, particularly if they have got a cranial nerve palsy, but it usually doesn't affect visual function. Children with squints tend not to get double vision, and they don't usually have binocular vision, and usually squint surgery won't restore binocular vision. So most of the time in children, if you do squint surgery, it's for cosmetic reasons. It's a bit unpredictable, the outcomes as well, particularly in children with cerebral palsy. So many children with cerebral palsy, for example, the parents don't particularly want them to have the surgery because they're not overly concerned about the cosmesis. It's done under general anaesthetic, and the muscles on the eye are moved, and it costs about £5,000 or £6,000 in the private sector. There are other claims for treatments for children with brain injuries and cerebral visual impairment, and I've come across patients who've got ongoing medico-legal claims going to Germany, for example, where there's a vision stimulation clinic where they claim to use electrical stimulation to improve brain function. This is not something that's provided on the NHS, and there isn't really any good evidence for these treatments. And the literature doesn't really include any ophthalmology inputs or assessments, and there's no really controlled studies for them, so they're not thought to be effective. But there is a good review article there published a couple of years ago. They're not something that's generally carried out. So in terms of the long-term prognosis, children may have some initial improvement of their vision for the first couple of years after a brain injury. And visual development occurs up to about the age of 7 or 8 years. So it can be difficult to give a long-term prognosis before that time. It tends to be stable after about that time, but sometimes the visual processing issues as a result of cerebral visual impairment are sort of masked by the child's other needs, and they may become apparent later as the child becomes more independent, starts going out more, doing more of their own things and gaining confidence. Strabismus, the squint, may worsen and become a cosmetic concern, or the child may become self-conscious about it as they get older. So I've got a couple of case examples of typical cases, medical legal cases involving brain injuries and visual issues in children. The first one is a child who had a traumatic birth. So the medical legal claim centered on the negligence around the handling of the birth. And the MR scan a week after birth showed extensive brain abnormalities as a result of the negligent birth. And the child had developmental delay, cerebral palsy, and microcephaly as a result of the brain injury. And I saw them at the age of 10. They'd been under ophthalmology because they'd had some treatment for amblyopia. And as a result of that, the treatment wasn't particularly successful, and they had very reduced vision, 1.6 logmar in the right eye, and 0.350 logmar left. So normal visual acuity measured by logmar is 0.0. And a level of 0.1, 0.2 is considered about normal in a child. But 0.350 is sort of moderately reduced in the left eye and very significantly reduced in the right eye. They had a right convergent squint with their eye turning inwards, and they had nystagmus, and they wore glasses for astigmatism. And the parents reported that they were not able to judge steps and stairs. They had difficulties in cluttered or busy environments, and that they were not able to see things in their inferior visual field. They were tripping over things on the floor, not seeing their young cousins running around. They kept tripping over them. They didn't see the food that was on the bottom part of the plate. So it was likely that they had an inferior visual field defect or neglect, but it was very difficult to quantify it because they were not able to cooperate with visual field testing because they had developmental delay. They had been diagnosed with cerebral visual impairment and had been registered partially sighted. As I said, many children, even in this situation, haven't been because their treating ophthalmologists or orthoptists haven't sort of thought about it. And they had input from the visual impairment teachers, occupational therapy, and assistive technology. This is another example, a different type of a brain injury this time. This was a child, very sadly, who was in a road traffic accident at the age of 5 months when they were in a rear-facing car seat in their parents' car, and the car was hit behind by a lorry and was shunted into the vehicle in front. They had a CT and an MR scan which showed multiple head injuries with fractures and bleeding and effusions of the brain. And they had seizures and developmental delay as a result of this severe traumatic brain injury. 2 weeks after the road traffic accident, the child was noted to have poor visual behaviour and exotropia with the eyes turned outwards. And also the examination of the back of the eye showed that they had retinal hemorrhages in both eyes, which was basically bleeding just due to the severe nature of the head injury. At 3 weeks after the injury, they had sunsetting eyes, which is when the eyes sort of intermittently turn downwards, and abnormal pupil reactions. And this can be a sign of hydrocephalus, raised pressure within the brain. They didn't have papilledema, but they did have imaging evidence of hydrocephalus, and so they had a ventricular peritoneal shunt put in for post-traumatic hydrocephalus. And I saw them when they were age 5, and they had reduced visual acuity in both eyes, quite poor vision, one eye worse than the other. They had a divergent squint, and sort of signs and symptoms of cerebral visual impairment, which were very variable vision, difficulty with edges, difficulty with steps and stairs and copying shapes. And it was not possible to assess the visual fields as they had learning difficulties, and they were eligible to be registered as severely sight impaired. So just to coming to the end now, but just to mention that there are pitfalls in medical legal cases of children with brain injuries. I've had several cases now where the child's had poor vision and it's been thought to be due to a brain injury. One case, a child had a birth trauma and had very poor vision, and it turned out it was not initially apparent that the child had a problem with their retina, and they actually had a rare genetic eye condition, which was a retinal dystrophy, which affected their vision rather than the birth trauma. And I've had a couple of cases now where the child had hypoglycemia following birth, and so the claim has been around the management of the postnatal hypoglycemia. And the child's had very, very poor visual behaviour that has thought to be attributable to that. And then on examination, as the child's got older, it's been seen that the child has a condition called optic nerve hypoplasia. You can see this image here, where the optic nerve is really tiny and is underdeveloped. And that's the cause of the very poor vision for the child, nothing to do with the negligence. Optic nerve hypoplasia does go with endocrine abnormalities that can lead to hypoglycemia. So hypoglycemia may have been related, but wasn't related to the poor vision. So it's important to exclude non-ophthalmic causes of, ophthalmic causes of visual loss. So in summary, brain injuries in childhood very often lead to vision or eye problems. And so all children who've had a brain injury, this should be considered and assessed for. Cerebral visual impairment particularly is very common, and it's a spectrum of visual impairment ranging from very mild difficulties with a child with good vision to severe, profound visual impairment. And so therefore we need to consider the effects of a brain injury on vision, even if the child's not been known to ophthalmology before. And we've discussed some of the management options, such as adaptations to the environment and visual aids and technology. So if anyone's got any questions or comments, be very happy to address them. Thank you.
Thank you very much, Professor Ashworth. Appreciate your time today. I actually did have a couple of questions myself to ask you, and obviously for everyone who is still with us, thank you very much for being here. The chat function or the Q&A function atop, please place any questions you might have and I will happily ask them now. The couple of ones I was going to ask you is, first of all, with regards to your expert witness practice, I think it's also useful for the solicitors listening to know in terms of that what you do, slightly out of topic from the presentation itself. So, I mean, maybe it would be good to just advise them the areas of paediatric ophthalmology you can assist with and what types of cases you can look at, although they've probably got quite a good idea already from that presentation.
Yeah, so I'm a paediatric ophthalmologist. I also see young adults, and so I provide medical legal reports on all aspects of paediatric ophthalmology, not just brain injuries. That can include genetic eye conditions, clinical negligence, metabolic conditions, pediatric cataracts, pediatric glaucoma, pediatric tumours such as retinoblastoma. So it's very varied, actually, and also in young adults, particularly for conditions relating to those that genetic conditions, for example, that have been also relevant to pediatric ophthalmology.
No, thank you very much. And I wanted to ask as well, because obviously you mentioned within your presentation that there are quite a number of times where CVI, cerebral visual impairment, is not diagnosed correctly in the child. So my question is, and perhaps for solicitors who are watching this, either on the claimant or the defendant side, in your experience and recommendation, is there a particular way where the solicitor can effectively challenge an expert's conclusion if that hasn't been considered, either whether it's a clinical perspective or from the legal perspective, it may be slightly different.
So I think if you've got a child who's had a brain injury, I think you need to make sure that it has been considered. And the screening questions are quite a good way of trying to assess whether there is any of the typical symptoms of cerebral visual impairment. Even in children that haven't had a diagnosis, I'm often quite surprised, that the symptoms that the parents report are very typical. And the parents are often very relieved to be told, that there is an explanation for the difficulties that the child has. Even when the child appears to have good visual acuity, they're tripping over things on the floor, struggling with cluttered environments. With variability of visual function, they don't seem to be able to function when they're outside of their home environment, and things like that. So I think if you've got a child with a brain injury and the examining ophthalmologist hasn't considered it, then I think it's just ask the question: have they got any symptoms or signs of cerebral visual impairment? And as I said, there are many children who are under ophthalmology or orthoptics who haven't been diagnosed because their visual acuity is reasonable, and people have been concentrating on the amblyopia treatment, for example, and just people haven't really thought about it. But it's becoming much more well understood. Most of the ophthalmology meetings, paediatric ophthalmology meetings that I go to now, there's often a session on cerebral visual impairment, and the literature is expanding in this area.
So pretty much practically, obviously, if there's been a brain injury and there's some clear red flags, such as the child is not able to see certain things or is tripping up, then the solicitor should keep it in mind to raise that as something, if it hasn't already been done by the treating or the expert witness. Moving quickly on, I have a question here from Firdaus Patel at HCC. If a TBI has not been diagnosed post a road traffic collision, is poor visual behaviour indicative of a traumatic brain injury, a TBI? So the other way round, so to speak.
Yeah. Yes, I would say so. Or it certainly needs to be looked into. If it was a new thing, if you had a child who who had normal vision and then had a trauma and then had poor vision afterwards, yes, you'd have to certainly want that investigating.
Fantastic, thank you. Another one here from Jason Harries. What is the best strategy for arranging an assessment for a child with birth trauma? Is there a minimum age, and at what age can a final assessment be carried out?
So a child with birth trauma, we would normally, if there were concerns about the vision, usually what happens is that the pediatrician or the neonatologist has the child under follow-up and then raises some concerns about vision. Sometimes they make a referral anyway, even if they haven't got any concerns about vision when the child's very young. It depends on the situation. Sometimes the child's obviously very poorly for a while in hospital, and so the visual concerns are not an immediate worry. But so anytime the child can be referred at any time in a scenario where they're likely to have visual issues, like a known brain injury, and they should be kept under regular review through the period of visual development, which is typically, as I say, up to about the age of 7 or 8. Sometimes they're just kept under review by orthoptists and not ophthalmologists, sometimes both. And orthoptists as well are, learning more about CVI and are more clued up to making the diagnosis. And typically a child will be seen every 3 to 6 months, every 3 months if they were having ongoing patching treatment, every 6 months if there wasn't the need for that, up to at least the age of 7 or 8.
Thank you very much. And just lastly, for the moment at least, Ian Kerwin has asked, can a brain injury cause CSR or retinal leak in children?
Central serous retinopathy. I've never heard of that. I've only ever seen about 2 cases in children of central serous retinopathy. It's really, really rare in children.
So this might be relating to a specific case, and if that's the case, Ian, after this event, more than welcome to send through some more information, and I guess Professor Ashworth can review and to perhaps give some indicative guidance on that.
Yeah, I would say if a diagnosis of CSR has been made in a child, particularly in the context of injury, it might be something else. Because
Thank you
this
very
is so
much.
rare.
Wonderful. Well, oh, hold on. Sorry, we have another post just come through. Chloe Snedden has asked, are there any key factors which can help distinguish between CVI and ROP?
ROP. Well, yeah, that's a good question. Yeah, very long answer that would be required. So ROP, retinopathy of prematurity, is a condition which can lead to visual loss in itself. But if it's well treated and the child has good retinal function, then it may not in itself lead to much in the way of visual symptoms. So it's a difficult, it's something that needs to be teased out for an individual patient, how much of their difficulties are due to the ROP and how much are due to any brain injury that might have. Yeah, that's a complicated situation.
Complicated version. And again, suggests that there might be a claim in the background there with which relates to some of those questions. And again, Chloe, obviously, Professor Ashworth would be more than happy to consider that as part of her practice.
Yeah, that's quite a common cause of claims.
Absolutely. And again, sorry, we've had another one jump in from Marcus Weatherby. What implications does CVI have for choice of accommodation, single-story living, as an example?
Yeah, so often it is recommended due to the difficulty with steps and stairs that they would have single-story accommodation. Children with CVI would have single-story accommodation because they have difficulty with steps and stairs and changes in terrain. So that's often something that we can support that, yeah.
Yeah, absolutely. So that would be better for them. Okay, well, I think if I've not missed anything, I think that probably brings all of the questions we have to a close. Again, thank you everyone for joining us today. And again, Professor Ashworth, thank you very much for your time. Just to let everyone know, the webinar has been recorded and will be made available with the slides in the coming couple of days. And I think all of us will say that was a very, very interesting talk, very informative, and really, we appreciate your time today. Thank you very much. Other than that, I wish everyone a great day, and I'll speak to you soon. There's a lot of thank yous coming through. Just
my pleasure. Thank you.
Bye. Brilliant. Well, I'm going to click end now for the meeting. Thank you very much, everyone, and keep well.